Hey guys, Mike Verkest from the Second Shift Podcast here to talk to you about PIASE. Back in 1996, I had 2 certifications to manage, my state license and national registry. That was it. Fast forward 20-some years later, and what I would give to have just 2. Between my advanced certifications, ACLS, PALS, PHTLS, you name it, I'm looking at upwards of 10 certifications to manage. That's where PIASE saves my bacon. I simply add my certs, expiration dates, and bam, no more surprises. Take pictures front and back and share those credentials with whoever needs them. With the touch of a button, it's easy. Go to the App Store now for your device and search for PIASE, P-I-A-C-E-T, PIASE. Do it today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is going to be a podcast on a new push-dose pressor that we're seeing in the flight environment. When I saw that Air Methods was now using this as a push-dose pressor, I was really excited. I actually came to Dan Davis in 2016 at a meeting in Beaver Creek, Colorado, and I asked him, why aren't we trying vasopressin? We'd seen some negative, effects with our standard push-dose pressors, epinephrine, phenylephrine. Obviously, epinephrine, we can get some increased myocardial ischemia. We can get some pretty increased sympathetic response, which can be negative to some of these patients that are highly sick, low pressures, already tachycardic. With phenylephrine, we've seen patients that actually have reflex bradycardia, which is obviously not a good situation as well. And based on my reading and some research, I had come across quite a few case studies about vasopressin being used in the anesthesia realm, in the OR suite for patients in massive hemorrhage, the same types of patients that we're seeing in the flight environment. And I thought, why not? Why can't we use that medication? Well, one of the big problems that we saw is when the AHA guidelines changed a few years ago, they removed vasopressin from the actual algorithm. Vasopressin prices shot up. Right? It's all about economics, supply and demand. Not selling as much vasopressin. Vasopressin isn't being used, so the price has to come up to meet the same overhead. That caused a ripple effect around the industry where I saw a lot of places actually remove vasopressin from the ambulances and from the helicopters. It wasn't necessarily pulled from the protocol, but it was removed based on, again, cost, because it's a low volume medication. We know that vasopressin is amazing in that sepsis patient. You know, you start some Levophed, you then add some vasopressin at that 0.04 units per minute. If they are vasopressin depleted, like many of them are, they will respond. 85% of patients in studies that were resistant to volume and Levophed initially were still hypotensive, responded to vasopressin. So we know vasopressin does an amazing job. It doesn't trigger the same catecholamine receptors. It triggers its own vasopressin 1, vasopressin 2, and vasopressin 3 receptors. And we know that there's really minimal, if you could say 0, side effects. We also know that it's great in those patients in the drip dosing for that upper GI bleed patient, and the dosing is between 0.2 and 0.5 units per minute. Well, why can't we use vasopressin as a push-dose pressor? And that's what I asked Dan Davis. Lo and behold, again, now it's being used. So different parts of the country for Air Methods is using this differently. I shouldn't say differently. They're using 2 different push-dose pressors. They can pick which one based on the type of patient. In patients that have profound hypovolemic shock, their severity level, right? We know shock index comes up. The duration of that hypovolemic shock may progress the patient to a point where that cardiovascular collapse is unresponsive to volume replacement and catecholamine infusion. Well, obviously in trauma, we're not going to give catecholamines. We're not going to give patients a Levophed drip, right? There's no science or evidence to say that that's beneficial. So essentially, they're catecholamine resistant. They're resistant to even volume. We carry blood products, but sometimes in that peri-intubation phase, we need to prepare these patients. We're seeing patients that don't do very well in that peri-intubation phase based on just how sick they are. And so this is a great way to augment them to a point where you can get some blood on board, start resuscitating them, get that airway established. There's also no myocardial ischemia risk, right? It's not triggering the same types of receptors. You're not having beta 1, beta 2 receptor stimulation. So I think that's really, really profound. When you look at specifically these patients that are profoundly shocky based on, massive hemorrhage, in the past, we would give phenylephrine. Well, we know, as I said before, we do have patients that have that reflex bradycardia, especially if we multi-dose these patients over and over. Epinephrine, you definitely have a beta 1, beta 2 stimulation. That's going to increase heart rate. That's going to increase the overall demand of that heart. And they're already profoundly sick. If their blood pressure is profoundly low, we know that anybody with a systolic less than 80 and tidal CO2 less than 25, that's an impending arrest situation. So again, I think using vasopressin is a phenomenal idea. So I wanted to put this out to the masses. I wanted to put this out and just let everybody know that this is actually being done now. This is a great option, and I think it's amazing. How do we mix this? Well, there's two thought processes here. Number one, we know that vasopressin is supplied 20 units in 1 ml, and so you can take a 100 ml bag of normal saline, add that 20 units, and by doing that, you have a concentration now of 1 unit for every 5 mils. So that's obviously a larger volume, and you're going to give doses of 2 units. So 2 units. So if it's 1 unit in 5 mils, you're going to give 10 cc's every 2 minutes if the systolic blood pressure in that massive hemorrhage patient, if that patient is a trauma patient, if that systolic blood pressure is less than 90. So any systolic blood pressure less than 90, associated trauma, you're going to give, again, that overall 10 cc's. So 10 cc's is going to be that 2 units. If for whatever reason you don't have a 100 ml bag, another way to do this is going to take, like we used to mix up maybe Versed or Valium. I would take a 10 cc flush. I would expel out 1 cc of that flush. I'd add my 20 units in 1 ml of vasopressin to that flush. I'd shake it up. Now you have basically 2 units per ml. So you're going to give 1 ml every 2 minutes, 1 ml every 2 minutes. So you have 5 different doses in that 10 cc flush. So that's another quick on the fly aspect to giving that vasopressin. Obviously, if you're giving only 1 ml, you need to make sure that you really flush that system, make sure you have a good patent line, and get that into a good large vein. Now, the onset is going to be very rapid. Onset is 1 minute. Duration is going to be 5 to 10 minutes. So again, really quick. If we were just to start a drip, the onset is going to be much slower, and so it's very important to understand we're not using a drip. We're using a push dose, small little aliquots, 2 units at a time. So I hope this is something that you guys can apply. If you have any questions, go ahead and email me at eric.bauer@flightbridgeed.com, or you could also email David Olvera, so david.olvera@flightbridgeed.com, and he can give you some more information as far as the air method side. If you have any questions, again, feel free to email or contact us, and we just thank you so much for sharing this podcast with everybody, seeing just immense growth that just tells us that we're doing the right things, and we really, truly are indebted to you. Until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.